Welcome to the Deep Dive. We're here to break down complex topics into, well, the really essential bits you need.
That's the plan.
And today, we're diving into Behcet's syndrome. It's definitely something important for your MSRA prep.
Absolutely.
Think of this as, getting straight to the high-yield stuff. Our mission, give you a clear, memorable overview so you can feel confident with those questions. We've looked through the notes, and honestly, keeping track of all these conditions, it can be tough. We want to help make Behcet stick.
Exactly. And Behcet's, while maybe not super common everywhere, like here in the UK, it's significant. Really shows how body systems connect.
Okay, so where do we start? A definition.
Let's do that. So, at its core, Behcet syndrome is a chronic autoimmune disorder. The classic thing you hear about, and it's often tested, is the triad.
The triad, right? That's the mouth ulcers.
Recurrent oral ulcers, yep. Then recurrent genital ulcers and uveitis, that's inflammation inside the eye.
Okay, ulcers, and eyes. Got it. But you said it connects systems. I remember reading something about blood vessels, too.
You did. That's actually key. A central feature is vasculitis, inflammation of the blood vessels.
Wow.
And that's why it's, potentially multisystemic. It doesn't just hit the mouth, genitals, and eyes. It can affect joints, skin, even the brain, because the blood vessels are everywhere, really.
Right, that makes sense. The vasculitis explains the spread. So what actually triggers it? Why does the immune system go haywire in Behcet's?
That's the million-dollar question. And honestly, we don't have the full answer. The thinking is it's a combination.
Like genes and something else.
Exactly. Genetic predisposition plays a part. And then it seems an environmental trigger, maybe an infection, something like that, sets off this exaggerated immune response in people who are susceptible.
Okay. Genes plus environment. A familiar story in autoimmune disease.
It really is.
Are there particular risk factors, like groups who are more likely to get it?
Yes, definitely. There's a noticeable pattern geographically. It's more prevalent in people from the Middle East, the Mediterranean, and parts of Asia.
Interesting. So geography matters. What about genetics specifically?
Well, certain genes, these HLA genes, human leukocyte antigens, they're involved. They help the immune system tell self from non-self.
Right.
And one in particular shows a pretty strong link. HLA-B51.
HLA-B51. Okay, that sounds like a key one to remember. Does having that gene mean you will get Behcet's?
Not necessarily, no. It just means you're more susceptible, increases the risk. It's not diagnostic on its own.
Gotcha. So susceptibility and the actual process, the pathophysiology, that's the immune system attacking blood vessels.
Pretty much. You get this abnormal immune activation. It leads to the vasculitis we mentioned. Think of it as the immune system overreacting massively to some trigger, maybe bacterial, maybe viral, in someone with that HLA-B51 background, for example.
And does that cause damage directly?
Yeah, it can lead to these things called immune complexes, forming basically clumps of antibodies and antigens. These get stuck in the blood vessel walls and cause inflammation.
Okay, so overactive immunity, vasculitis, immune complexes, triggered in susceptible people. Now, clinically, this must be tricky to diagnose sometimes. How do you tell it apart from other things?
That's a really important point. The differential diagnosis is crucial because, yes, symptoms can overlap.
Like what other conditions?
You'd think about other types of vasculitis, obviously. Things like systemic lupus, erythematosus, or SLE, even Crohn's disease because of potential gut involvement, and other autoimmune conditions generally.
So how do you narrow it down?
A big clue often is that combination of recurrent oral ulcers and recurrent genital ulcers. That specific pairing points more strongly towards Behcet's than many of the others.
Right, that combination is pretty unique.
It's a key feature. Now, you mentioned earlier it's not that common in the UK.
Yeah, what are the numbers roughly?
So here in the UK, the estimate is maybe 1 in 10,000 to 1 in 20,000 people, but head towards the Eastern Mediterranean, Turkey, for instance.
Much higher.
Considerably higher, yes. And the typical person affected is interesting, too. It tends to show up more in young adult men.
Young men, what age range?
Usually between 20 and 40 years old. That's the peak onset.
Okay, 20s to 40s, more common in men, specific regions, and that HLA-B51 link again.
Exactly. And maybe around 30% or so of patients actually have a family history, which again points to that genetic element.
Right. It's starting to form a clearer picture. So let's talk about what the patient actually experiences, the clinical features.
Okay. Presentation can be really varied because of the potential for multiple systems to be involved. But almost everyone, nearly 100%, gets the recurrent, painful oral ulcers. They're a hallmark.
Okay, mouth ulcers are almost guaranteed. What else?
Genital ulcers are also very common and obviously distressing. Skin lesions are frequent too, things like pustules, almost like acne but not quite, and erythema nodosum.
What's that like?
Erythema nodosum. They're these tender red lumps, usually on the shins.
Okay, skin stuff too, and the eyes?
Eye involvement, the uveitis, is a big one. It can be serious, potentially affecting vision. Then you can get arthritis, often in the big joints like knees and ankles.
Joints as well. Wow, it really does get around. Anything else?
Yes, you can get central nervous system involvement, headaches, sometimes even meningitis-like symptoms. And because of the vasculitis, there's a risk of thrombophlebitis, which is vein inflammation with clotting, and DVT's, deep vein thrombosis.
Blood clots. Okay, and the gut. You mentioned Crohn's earlier.
Right, GI symptoms can happen too. Things like abdominal pain, diarrhea, sometimes colitis that looks a bit like inflammatory bowel disease.
Okay, that is a lot of potential symptoms.
Yeah.
Mouth, genitals, skin, eyes, joints, brain, blood vessels, gut. How do you possibly remember all that for an exam?
Yeah, it's a challenge. A mnemonic can definitely help here. How about MOGS-JBBG?
MOGS-JBBG. Let's break that down.
Sure. M for mouth ulcers, O for ocular or eye involvement, G for genital ulcers, S for skin lesions.
Okay, MOGS.
Then J for joints, arthritis, B for brain, CNS, the other B for blood vessels, thrombosis, and the final G for gastrointestinal. MOGS-JBBG.
MOGS-JBBG. Mouth, ocular, genitals, skin, joints, brain, blood, gut. I like it. That actually helps pull it together.
Good. Hopefully that's useful.
Definitely. So if you suspect Behcet's based on these features, how do you confirm it? Is there a specific blood test or scan?
This is where it gets tricky again. There's actually no single definitive diagnostic test.
Oh, right. So it's more clinical.
Exactly. Diagnosis is based primarily on the clinical picture, putting together those characteristic symptoms we just listed using, say, MOGS-JBBG, along with a good history. But investigations are used to support the diagnosis and, importantly, rule out other things.
Okay, what kind of investigations?
You might do blood tests, maybe check inflammatory markers like CRP or ESR. HLA, B51 genetic testing can be done, though remember, it's not diagnostic alone.
Supportive, not diagnostic.
Got it. A biopsy of a skin lesion or one of the ulcers can sometimes show characteristic vasculitis, which helps. A detailed eye exam by an ophthalmologist is crucial to look for uveitis.
Right. Checking the eyes makes sense.
And depending on symptoms, imaging like angiography to look at blood vessels or an MRI for the brain might be needed.
What about that Pathophysiology test I've heard about?
Ah, yes, the Pathophysiology test. That's where you prick the skin with a sterile needle.
And what happens?
In some people with Behcet's, they get this exaggerated inflammatory reaction. A little pustule forms at the prick site within about 24 to 48 hours.
So a positive test is helpful.
It can be suggestive, yes, but it's not always positive even in people with Behcet's. And it can sometimes be positive in other conditions or even in healthy people in certain regions. So again, it's supportive, but definitely not definitive.
Okay, lots of supportive pieces, but diagnosis is mainly putting the whole clinical puzzle together.
That's a good way to put it.
So once you have made the diagnosis, what's the approach to management? What are the goals?
The main goals are, well, firstly, to control the symptoms the patient is having right now during a flare. Secondly, to try and prevent future flares, or at least reduce their frequency and severity. And thirdly, really importantly, to prevent long-term complications and organ damage.
And how do you achieve that? Sounds like it needs a team approach.
Absolutely. It's usually managed by a multidisciplinary team. Rheumatology is often central, but ophthalmology, dermatology, neurology, gastroenterology might all be involved, depending on what's affected.
Makes sense. What about treatments? Medications?
Medications are definitely the cornerstone. For acute flares, corticosteroids like prednisolone are often used to quickly bring down inflammation.
Okay, steroids for flares. What about long-term?
For long-term control, we use immunosuppressants. Drugs like azathioprine or methotrexate are common choices to sort of dampen down that overactive immune system.
Right, the immune suppressors.
And then for cases that are more severe or don't respond well to those, we might move on to biologic agents. Things like infliximab, which targets TNF-alpha, can be very effective.
Biologics too. Okay. Anything else?
Beyond the drugs, supportive care is vital. Pain relief, topical treatments for ulcers, that kind of thing. And patient education is huge, helping people understand their condition, manage symptoms, know when to seek help.
Sounds like a very individualized plan is needed. What's the outlook generally? The prognosis?
It's quite variable, honestly. It really depends on how severe the disease is and which organs are involved. The key thing to remember is that it's a chronic condition.
Meaning it doesn't just go away.
Right. It typically follows a relapsing remitting course. So periods where symptoms flare up, followed by periods where things quiet down, sometimes for quite a while.
Okay, ups and downs.
But the good news is with proper management, regular follow-up, adjusting treatments as needed, many people with Behcet's can lead pretty full and productive lives. Quality of life can often be maintained quite well.
That's encouraging, but there are potential long-term problems if it's not managed well.
Yes. Unfortunately, complications can occur, and they can be serious. That's why management is so important.
What sort of complications are we talking about?
Well, the uveitis, the eye inflammation, if it's severe or persistent, can lead to permanent visual impairment, even blindness in some cases.
Wow, okay. Eyes are a major concern.
Definitely. Chronic joint inflammation can lead to joint damage over time. If the gut is involved, you can get ulcers that might rarely perforate.
A perforation, that's serious.
Very. Neurologic involvement can lead to long-term issues too. And that increased risk of blood clots, DVTs, and arterial thrombosis is a significant concern throughout.
So managing it well is critical to avoid those outcomes.
Exactly. Regular monitoring, catching flares early, treating appropriately, it all aims to minimize the risk of these quite serious complications.
Okay, that really puts it into perspective. So
Yeah.
just to recap the key takeaways for Behcet's. It's this chronic autoimmune vasculitic condition. Remember the classic triad? Mouth ulcers, genital ulcers, uveitis. Think about the risk factors. Younger men, specific regions like the Med and Middle East, and that HLA-B51 link.
Right, though B51 isn't diagnostic alone.
Got it. And the clinical features are broad use, MOGS-JBBG, to help remember. Mouth, ocular, genital, skin, joints, brain, blood vessels, gut.
Good mnemonic to keep handy.
Diagnosis is mainly clinical, piecing the puzzle together, supported by investigations like eye exams, biopsies, maybe pathology, but no single test confirms it.
Correct.
And management involves controlling flares with steroids, long-term immunosuppressants or biologics, aiming to prevent those serious complications like blindness, clots, or organ damage.
You've nailed the key points there. Understanding that multisystem potential and the diagnostic approach is vital for the MSRA.
Absolutely. So as you're revising, keep MOGS-JBBG in your head. Remember HLA-B51, but know its limitations, and focus on that clinical pattern recognition.
And perhaps a final thought. It really highlights how conditions can present in varied ways, doesn't it? The importance of looking at the whole patient and connecting seemingly unrelated symptoms is, well, fundamental in medicine.
Right. That's a really great point. A good reminder beyond just this condition. Okay, well, we hope this deep dive into Behcet syndrome has given you a solid, high-yield foundation for your MSRA prep.
Hope it helps.
And if you're looking for more resources, definitely check out PassThemSRA.com. And there's also FreeMSRA.com for additional support.
Great resources.
They really are. Okay, that's us for this deep dive. Keep up the hard work with your revision.